Please raise your hand if you can hear me. Perfect. That's great. Well, thanks for coming tonight, everyone. We are thrilled that we're launching our 4th season of this Cafe Scientifique session with new approaches to treating cancer. So our 4th year, and we were very, the past 3 years, grateful for the support of the Canadian Institutes for Health Research for helping us launch these events. And it's been the Science Center in partnership with Mount Sinai Hospital. And then last year we were also lucky to partner with CIHR's training program in regenerative medicine. So that's given us access to a lot of leading experts in this area. So we'd like to thank all our partners tonight for helping make this event possible, specifically the CIHR and the Science Center, Mount Sinai Hospital, and the CIHR's Training Center in Regenerative Medicine. So I'd also like to introduce our panel for this evening. First of all, we have Dr. Stephen Gallinger. And Dr. Gallinger is a clinician scientist and surgical oncologist with an interest in gastrointestinal cancer genetics, specifically of colorectal and the pancreas. He's also a senior investigator at Mount Sinai Hospital and head of the division of hepatobiliary and pancreatic surgical oncology with the University Health Network and Mount Sinai Hospital. So he'll be our first speaker this evening. And then we have Dr. Sheila Singh in the middle up at our panel. And Dr. Singh is a scientist at McMaster's Stem Cell and Cancer Research Institute. She's also an assistant professor in the Department of Surgery at McMaster. And she has a research program that's centered on the study of cancer stem cells. So that should be very interesting tonight. And our third speaker is Dr. Armand Keating. And Dr. Keating is the director of the cell therapy program at the Ontario Cancer Institute of Princess Margaret Hospital. And he's also director of Division of Hematology at the University of Toronto. Dr. Keating obtained his MD from the University of Ottawa, and then also completed a research fellowship at the University of Washington and at the Fred Hutchinson Cancer Research Center, which is in Seattle. Then, upon moving to Toronto, he was a cancer research scientist at the National Cancer Institute of Canada. And I'd also like to welcome Donna Francis from the Science Center, who's going to explain how this evening is going to work. Donna.
Thanks, Karen. So my name is Donna Francis, and I would like to welcome everyone here to tonight's Cafe Scientifique. Can I just get a quick show of hands to let me know how many people this is your first time at a cafe ever? Awesome. Lots of new faces. The speakers are allowed to raise their hands as well. That's right. They're in good company. Hopefully this will not be your last Cafe Scientifique event. The way that it works is this event is designed to generate some discussion on interesting health-related topics in science. So don't think of it as just being a way for you to find out new information. Think of it as a way for you to also generate some conversation amongst your friends and family, and a way for you to also get some of your concerns and questions answered as well. Those are all part of the ideas that make this such an engaging event. So I'll be looking forward to hearing some great thoughts from you as well. So before we get started, I thought we'd just put this topic into perspective, new approaches in treating cancer. I think everyone in the room generally knows someone who has been affected by cancer, and I did a little search to see what some of the statistics on cancer in Canada were, and I came up with some really interesting data. Cancer is the leading cause of premature death. 3,340 Canadians are diagnosed per week. This is according to the Canadian Cancer Society. And 1,470 Canadians die of cancer each week as well. 40% of women, 45% of men will develop some form of cancer in their lives. However, after those sobering statistics, the September 2010 report, which just recently came out, says that as a resident of Canada, the statistics look pretty good in terms of survival. The survival rates, and these are 5-year survival rates that are generally calculated, and it's a comparison between the survival possibilities for someone who's been diagnosed with cancer versus someone who hasn't been. And the survival rates in general for cancer in Canada are 62% for someone who has been diagnosed versus someone who hasn't. And these survival rates have been consistently on the rise. As this is a topic that touches us all, and where their advances are making very real changes in people's lives, I think we're all looking forward to hearing from our speakers on the ideas of new approaches in treating cancer, some of the reasons why those cancer survival rates are really increasing in Canada. So without further ado, I'll turn it over to our speakers, and the way that this works is each one of them will speak one after the other for about 10 minutes, and they're going to speak on their own topic of expertise, and they're all speaking to the idea of what are the new approaches in treating cancer, what's different from what's been out there before. And once they've all spoken, we'll have a little 15-minute break, and then we'll have a nice little 40-minute discussion. So get ready, get comfortable, and we'll hear from our first three speakers.
Hi. My name is Steve Gallagher. I'm a surgeon down here at UHN, Princess Margaret Hospital and Toronto General Hospital. Actually, I've been asked to introduce the broad topic of cancer treatment before I get into any too specific. So, again, the audience, I suspect, is quite mixed with varied levels of background, and I don't have slides like I'm used to speaking to. So we're actually much more comfortable speaking to peers and colleagues at meetings than to the general public, but I've done this before, and I'm happy to take questions, and hopefully we can address what you're interested in. Cancer is not one disease. People often say, you know, my aunt had cancer, or someone I know had cancer, as if it's arthritis or diabetes. It's not. It's a very complicated disease, and each of the cancers is very different. Even many people with the same cancer are very different. So there's no single treatment or method that necessarily will work for the same two people. So what we often hear in the clinic is, you know, my uncle had chemotherapy and got really sick, so I'm not taking chemotherapy. But in reality, your uncle had a very different cancer and got different chemotherapy. And even if you got the same chemotherapy that you're going to be given, it could be very different. So these are some of the generalizations that people make that are really misgivings. Cancer treatment in general is divided into three broad groups, and that's because of the specialization more than probably anything else, because in reality we all work together. It's called multidisciplinary care. So in general there's surgery, chemotherapy, and radiotherapy, and there are variations on those themes. I happen to be a surgeon, and surgeons do what you think they do, generally cut out or we call resecting tumors. And there have been significant advances in surgery, primarily in the extent of surgery that we can do, the safety of surgery. This province has actually been very much a pioneer in what's called centralizing, meaning complex surgery has been centralized to just a few centers because there's a lot of evidence that practice makes perfect, meaning high volume centers have better outcomes than lower volume centers. And it's been hard sometimes for surgeons to swallow that fact, but it's generally been true for complicated cancer surgery. So cancer surgeons cut out the tumors. Medical oncologists generally give chemotherapy or what's called biologic therapy. These are drugs that are either given in pill form or intravenously on various schedules. And radiation oncologists deliver radiation either externally or sometimes locally. So those are the three general ways that cancer is treated. There's other ways that we can discuss, and some of you probably want to discuss alternative forms and dietary forms and prevention and all other topics which are important as well. My own personal interest in is what's called hepatobiliary surgery. It's a big long word, HPV. It stands for liver and pancreas surgery. We deal with some of the nastiest cancers, and one of the ones that I deal with is called pancreatic cancer, which some of you have heard about, and it's an area that I've been passionately interested in for about 20 years now. It's one of those areas that either you are really excited about it or you can't stand the thought of doing it. And for those who like the challenge, we're excited. For those who are nihilistic and haven't seen much of what looks like very little progress, then it's easy to be nihilistic. The reality is there have been significant advances in this disease, and I'll tell you a story which I think exemplifies the progress in this area. There's about 1,200 new cases of pancreas cancer in Ontario a year. There's about 5,000 breast cancer and about 5,000 colon cancers, and that kind of puts it in perspective. Breast cancer survival rates are about 60 or 70%. Colon cancers are roughly the same. The pancreas cancer rates are about 2% survival, and that's the way it's been for many years. So that's the dismal side of the story. And of about every 100 patients that we see, 20 are operable, and 80 can't even be operated on. And that's because the disease seems to present at a rather late stage and often is either what's called locally aggressive, meaning invading critical structures that we can't remove, or it's already spread, meaning it's metastatic. And surgeons over the past 50 years have come up with creative ways of removing tumors, and we can do it much more safely with very low death rates from the surgery, and we've pretty much maxed out in our ability to take out big pieces of the pancreas safely. So we now have very good safety, surgical safety results, but we haven't really impacted the survival. We've tried to take out more tissue or different ways of taking it out, but it hasn't really changed things, and we know that because of what are called randomized trials, where you take 50 patients and do it this way, you take 50 patients and do it that way, and look at the differences. And it's been done for this disease, and there's nothing new that we can do. There are some twists that I won't get into. But where we've actually seen significant differences, and this is just a recent story, is really in the area of genetics. And I happen to be interested in cancer genetics, so that's my particular bias. And I study what's called predisposition, or hereditary predisposition, trying to figure out which people in this room are more or less susceptible to a disease. Not everybody's going to get cancer, but a third of us will probably get cancer. And some of us might get pancreatic cancer, and we'd like to know that in advance. So what we've learned in the past few years is that there are genes that increase risk up to 5 or 10 times. And we're screening some of those people with MRI every year. But just recently, there's a really interesting example of what we call translational or bench to bedside research in molecular biology. You've heard of the breast cancer gene, BRCA2. BRCA2 is a gene that is well known in the breast cancer world. Women and men with breast cancer with mutations in that gene that's been passed down through their families are at very high risk of breast cancer. But what wasn't appreciated was that these same people are at higher risk of pancreatic cancer. And the gene got its name from the discovery of breast cancer genes, but it took many years for people to make this connection with other diseases like pancreatic cancer.